Hello, good afternoon everyone, respected teachers and all my colleagues. My topic today is anatomy of the heart. I had prepared this keeping in view that it is for undergraduate students. So pardon me for the not so intricate details of my PPT. I have kept it very superficial. In short, I'll try to include some clinical points which will help you clinically in medicine. So this is the external features of the heart. This is the anterior view. In anterior view, you can see that major part of the heart is formed by RA and RV, the anterior surface, while the posterior surface is majorly formed by the LA part. So many people have misconception कि पीछे में जो है LV है, but actually the LA on which the heart is resting, and the heart is placed like this on the LA side. Then you can see in RA and RV there is a right anteroventricular sulci. In LA and LV there is a left anteroventricular sulci. In the right anteroventricular sulci you have right coronary artery giving its branches. In the left atrioventricular sulci you have the left circumflex artery, while in the interventricular sulci, which is internally formed by interventricular septum and externally by the sulci, you have left anterior descending artery. Okay. One more point I would like to point out: the most anterior structure in the heart is the pulmonary artery. Okay. So whenever you have trauma, pulmonary artery is the first structure to get damaged. This is the posterior surface of the heart. Again, I would like to point out here. You can see circumflex. It is encircling the left atrium. It is hugging the left atrium, and it is enclosing the left atrium. So the clinical point here is you have many cases of mitral valve prolapse, right? In clinical exams, it is always asked to you, mitral valve prolapse patients always have atypical chest pain. So why do they have atypical chest pain? The reason is in this anatomy. It is the developmental anomaly of the posterior mitral leaflet. It goes and it encroaches upon the left circumflex artery, and it causes spasm of the left circumflex artery. That's why they have atypical chest pain, which is almost like angina, but it is atypical. It does not increase on exertion, it does not subside on rest, but it is very atypical, and they complain of commonly chest pain. So this is the reason why they have chest pain. Then secondly, I would like to point out in the posterior interventricular sulci, you have the posterior descending artery. Again, this is very important in dominant circulation. As you all know, 85% of the hearts are normally right dominant, 15% are 8% are left dominant, while 7% are co-dominant. So it all depends कि PDA कहाँ से आ रही है. PDA RCA से आ रही है, PDA left circumflex से आ रही है, PDA दोनों या PDA RCA से आ रही है और PLV LAD से आ रही है. That means that the heart is co-dominant. So it helps us sometimes during angioplasty if you want to triage which artery to save. If RCA is small, but if it is giving PDA, then our approach is that we should save that PDA rather than letting it go. Then we have dissected the heart out. Here you can see the interior of the right atrium and the right ventricle. You all know there is a smooth part, there is a rough part. Smooth part is known as sinus venereum. Rough part is made up of pectinate muscles. They are like teeth of a comb. Here you have fossa ovalis. This is the limbus. Here you have opening of the coronary sinus. And here I can't delineate it, but this is the triangle of Koch, where you have the AV node. Yeah, there is tricuspid annulus, coronary sinus, and tendon of Todaro. And here you have somewhere AV node, while SA node is on the junction of crista terminalis, where SVC joins. Okay, that is on the upper part. You have the SA node. Then many times it is asked, how is heart suspending in the mediastinum? So the reason is this fibrous skeleton. Heart को bone नहीं होता है, but heart में ये fibrous skeleton होता है. On basis of this, you have all the four walls. You have on the basis of this, the atria and ventricular muscles are attached, and this is how heart is suspended like this. So another peculiarity is, see, tricuspid, mitral and aorta, they all are attached by a common fibrous ring, okay? But pulmonary does not have the fibrous ring. Pulmonary is different. This importance comes in actually congenital cardiology, where it is known as the conus is different. Pulmonary ka conus is always different from these three walls. So this is the central fibrous body known as right fibrous trigon. This is the left fibrous trigon, and between aorta and pulmonary you have the tendon of infundibulum. Clinically, in pediatric cases, this is important for CVTS surgeons. We have to tell them whether the conus is present or not. According to that, the approach changes. Not so much important for you guys, but just I wanted to tell you. Again, this is a view of the heart with cross-sectional view of the walls. You can see the mitral valve is saddle shaped. Tricuspid valve is having 3 leaflets. This is the pulmonary. This is the aorta. Aorta is giving 2 coronary arteries. Another misconception I'd like to clear you. Heart में कितने papillary muscles होते हैं? Left ventricle में. What do you think? How many papillary muscles you have? So usually you say there are 2 papillary muscles in left ventricle. There are 3 papillary muscles in right ventricle. Yes, you are right. But how many chordae are there? Okay, so chordae are above 100. Each papillary muscle has 6 heads and each head gives 10 to 12 chordae. So chordae are nothing but fibrous collagenous structures and they are very friable. Most commonly in inferior wall MI, if you have MR, mitral regurgitation, it is usually due to, if it is acute MR, it is due to rupture of chordae. And these chordae are very sensitive and most common culprit lesion is the left circumflex artery. So left ventricle you have 120 chordae, in right ventricle you have also 60 to 70 chordae. So that misconception you need to change कि 2 papillary muscle है तो 2 या 3 chordae आते, ऐसा नहीं है. Each papillary muscle has 6 heads. Each head gives 10 to 12 chordae. Okay. This is the aortic valve. Here you can see nodule of Aranti. Then this is the lunules, and then you have orifices of right and left coronary arteries. See here, I can say that sometimes हम कहते हैं anomalous है coronary artery. So sometimes it is the NCC which gives rise to RCA and LCA. Or sometimes you have RCC which gives rise to both LCA and RCA. Or sometimes you have from left side both RCA and LCC coming. Also they say कि METs heart में हो नहीं सकते, heart में METs हो सकते हैं because heart also has lymphatic drainage. So lymphatic drainage of the heart is just like our arterial supply. बहुत simple है. The anterior ventricular trunk, it follows the LAD. The posterior ventricular trunk, it follows the PDA. Both combine, it goes and forms right cardiac channel. This goes up, combines with the obtuse marginal trunk, forms the left cardiac channel. RCC and LCC combine and drain into main supracardiac channel. They drain into the cardiac lymph node. They drain into the light lymphatic duct and through that IJV. So lymphatic drainage heart को होता है. There is a misconception again, heart को lymphatic क्या है? So this is there. That's why METs are also common in heart. This is the just description of what I have explained. Then again venous drainage. Venous drainage is again important. 60% of the venous blood in the heart is drained by the coronary sinus, while 40% is drained by the anterior cardiac vein and Thebesian's vein. Coronary sinus, there are many branches, tributaries, small cardiac vein, middle cardiac vein, posterior vein of LV, oblique vein of LV, great cardiac vein. The clinical importance is in echo sometimes, in plaques view, if you see coronary sinus is dilated, it is a telltale sign that patient, adult patient, is a telltale sign that patient might be in failure. Because coronary sinus getting dilated, most common cause in adults is congestive heart failure. In pediatric cases, the causes are very different. But for adults, for your medicine point of view, I'm saying that coronary sinus, always look at coronary sinus when you're doing echo. It gives you an idea about the LV-EDP. क्योंकि वो बैक प्रेशर ही हो रहा है पूरा ट्रांसमिट. तो कोरोनरी साइनस डायलेटेड है मतलब क्या है, आरए में ज्यादा है, आरए में प्रेशर ज्यादा है मतलब आरवी में ज्यादा है, यानी वो पूरा बैक प्रेशर डिनोट करता है. सेकेंडली अनदर कॉज ऑफ डायलेटेड कोरोनरी साइनस इज लेफ्ट साइडेड एसवीसी. व्हाई? बिकॉज लेफ्ट साइडेड एसवीसी इज नथिंग बट द रेमनेंट ऑफ द oblique vein of left atrium. यहाँ पे जो है this goes and forms the left sided SVC. So if there is left sided SVC, that is another reason of having dilated coronary sinus. Again, the arterial supply, there you have from right coronary sinus RCA, from left coronary sinus left main, LCX and LAD. Here there are many anomalies possible. Every anomaly is possible. From right coronary sinus you can have left as well as right arteries coming. Sometimes you have dual, like from RCA will give an LLD, LMCA will give one LLD. Dual circumflex, sometimes you have dual RCA. Most common anomalies are common in top because in petrol. Hello. Because in tetralogy of Fallot patients, see, those are conotruncal abnormalities. So when the conus is rotating, these arteries, they don't go and combine to the left coronary sinus or right coronary sinus. They go and combine to any sinus. So mostly in TOF and in DTGA, you have anomalies of coronary arteries common. As my learned friend has already said, how to identify the blocks in arteries based on ECG. So very simple है, proximal LAD है, septal के पहले गया तो V1 में रहेगा, V1 में नहीं है तो S1 के बाद है. जितना जितना distal you go on getting, so V2, V3, V4 like that, till V4 it is LAD. If V5, V6 is getting involved, you think of left circumflex. And in RCA, if in ST elevation lead 3 more than 2, think of RCA lesion. If ST elevation lead 2 is more than lead 3, think of LCX lesion. Another thing I'd like to say is SA nodal artery, 60% it comes from the RCA, 40% it comes from the left circumflex. This is again very important. It helps us to triage during angioplasty. Then again you have a conal branch. Conal branch is not denoted here. Conal branch is very notorious. Conal branch is the most notorious artery to cause VT during plasty. If our guide wire or your catheter just slightly irritates the conal branch, it typically RVOT ka VT aata hai, LBBB pattern. It is very, very notorious. Other things you know, the branches and the cores of the arteries. The nerve supply of the heart, you have a pressure area. Pressure area is the cardiac activatory area. Then you have depressor area formed by nucleus tractus solitarius, nucleus ambiguous. They increase the activity of the vagus nerve and decrease the heart rate and the blood pressure, while the pressure area increases the sympathetic activity. So the vagus nerve acts via the superior and inferior cardiac branches and thoracic cardiac branches of the right and the left vagus. They give off the preganglionic branches, and then they have the postganglionic branches. While in sympathetic, you have the postganglionic branches which supply the heart through superior, middle, inferior. The main point I want to tell you here, see, the function of right and left vagus is very different. Both right and left vagus, they cause bradycardia, but the mechanism of both is very different. Right vagus causes bradycardia through decreasing the SA nodal firing, while the left vagus decreases heart rate through increased refractoriness of AV node. So the mechanism are very different. So preferably when you are having AV NRT patient, go for the right vagus rather than the left vagus, because you need to decrease the SA nodal activity. Okay. This is what I have shown in the flow chart, what I have just told you. Thank you.